Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours. Get down in the cave and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
My guest today is Dr. Shane Mangrum, who is an experienced board-certified physiatrist at Axion Spine and Neurosurgery here in the Atlanta, Georgia metropolitan area. Dr. Mangrum is a double board-certified physician in physical medicine and rehabilitation as well as sports medicine. He takes a holistic approach to spine treatment and other musculoskeletal disorders, specializing in non-operative interventions. Dr. Mangrum earned his undergraduate degree in organismic and evolutionary biology from Harvard College in Cambridge, Massachusetts, and attended and completed medical school at the University of Utah in Salt Lake City. Dr. Mangrum then finished medical training with residencies in physical medicine and rehabilitation at the Mayo Clinic and the University of Utah. Today we talk about low back pain and get Dr. Mangrum's insight on this very common condition that seems to affect us all. So please enjoy this great conversation I had with Dr. Shane Mangrum. All right, good morning, everyone. Welcome to the Pod of Inquiry. I'm here with actually a pretty good friend of mine and colleague, Dr. Shane Mangrum. Shane, good to see you. How you doing?
Thank you. Thank you for having me. It's always good to see you. I always like to talk to you and learn from your cutting edge stuff.
Well, it's a mutual thing for sure, and hopefully the audience are going to get some great pearls. We're going to discuss something today about, I would say it's a pretty relatively common condition, low back pain. And both of us were discussing that we are or were sufferers. And so we'll get into that. But before we start, tell the audience what you're doing, how you got into it, and then we'll get into the meat of the low back pain dilemma.
Yeah, so I am a physiatrist, which is, it's an interesting specialty in medicine. And, most people have not ever heard of physiatry. And I kind of stumbled into it. I went into medicine thinking maybe I'd be a small town family doctor, or, I had ideas. But as I went through medicine, I had a little bit of a hard time finding exactly what I wanted to do. And then I worked for a summer doing research with an anesthesiologist that did pain, and I liked it. I thought it was interesting. I liked the idea of helping people with pain, but in that clinic, there was a physiatrist, and I'd never heard of it. And so I kind of talked to him a little bit and got to know what he did and found it interesting. And it was that kind of spurred my interest, and eventually I did my residency and training in physical medicine and rehab, or physiatry. I practice in kind of the greater Atlanta area, and I've been here for about 10 years and practiced before that in Idaho for about 10 years.
So your group is a very interesting group too, because not only do you have the physiatry pain management, but you also have the neurosurgery component right in your practice.
Yeah, it is nice. I really like having a multidisciplinary practice. And so I work with neurosurgeons, and the practice, we end up seeing, lots of spine-related pain, a lot of neck pain and back pain, but certainly together with that, often those issues overlap. We see people with foot pain and leg issues, or shoulders and hips. And so we see a lot of different things. But yeah, I work with neurosurgeons that are really excellent surgeons, and I like that relationship of having, again, more than one discipline. And so I can look at a case and say, hey, what do you think of this? And that collaboration, I think it makes me a better practitioner in what I do.
Yeah, I think that's pretty ubiquitous in almost every specialty. We sometimes get entrenched so much and never read outside of our journals. And then all of a sudden you read in something, it's like, wow, I could be doing that, So yeah. It's kind of an eclectic approach, I think, toward optimal care.
And it's common with physiatry, actually, that physiatrists often work in, as a specialty, and again, I don't know if you necessarily want to go here now, but as a specialty, it started after the, some of the world wars and taking care of, veterans coming back from the war with amputations or spinal cord injuries or head injuries. And that's really where the specialty of physiatry started. And so it's relatively newer. And, as part of that process of taking care of those kinds of injuries, those people also had shoulder pain and back pain. And so it really, the specialty has morphed, and there's this strong musculoskeletal component of it now, but really it started with taking care of, again, with complicated injuries that needed rehabilitation. And I think that affects the lens through which we as physiatrists take care of people. It's this very functional approach of, somebody's had a bad injury, and it's, one, how can we, address pain and those kinds of issues, but it's very oriented towards how can we improve function and quality of life.
So just to get a more general understanding to the audience, would you say that, and this may be very unfair stereotype that I'm going to make, and if it is, just correct me right away, but it seems to me that physiatry has more of a neurological or neurology overlap versus anesthesia pain medicine, more pharmacologically. Is that kind of a fair, or do you want to kind of get me straight on that?
Yeah, I mean, it is, there is a lot, potentially more overlap with neurology. Again, some of that relates to the training. So as a physiatrist, as we go through our training, we spend a fair amount of time in the inpatient rehabilitation unit. And so we will take care of people that have had strokes and head injuries and a lot of neurologic kinds of things. And so that's baked into the training program, that everybody does some of that. And then some people choose to be, again, kind of more focused on musculoskeletal medicine, and they may do a fellowship in spine or sports or things like that.
Mm-hmm.
And so that perspective, I think, is very different than anesthesia, where an anesthesiologist does training in, again, they do kind of a transitional year or, a general surgery year, and then they do anesthesia training. And they don't get the same exposure to musculoskeletal kinds of things. And the other thing that physiatry does, we do EMGs and nerve conduction studies. Right. And neurology is the only other specialty that does that. And so, again, we have that neurologic basis of having to, do some of that nerve testing. And so, again, I function sometimes as a poor man's neurologist, on some issues.
Yeah. Well, so I actually know more physiatry pain management specialists than I do anesthesiology pain management specialists. And what do you think the percentage breakdown in the United States is? What percent are anesthesiology based trained, and what percent are physiatry based trained?
I don't know, to be honest. I would guess it's 50-50. I mean, okay. Again, and those percentages have morphed over time, in that, again, a lot more physiatrists go into the specialty with the idea specifically of doing spine and pain.
Right.
And so I think that certainly that balance has shifted, whereas for the longest time, it was mostly anesthesiologists doing it.
Right. Oh, well, like you say, it's a relatively new specialty. So,
and that's especially true with the fellowships in pain and musculoskeletal medicine are much, even in the last, again, I don't know, 20, 30 years, like that's relatively newer.
Right. So we're going to talk about low back pain today. And before we started recording, we were each lamenting our situations with low back pain in the past and everything. So I guess the first question is, how much does low back pain make up of what you see percentage-wise? It's got to be a pretty significant amount.
Yeah, so I see, again, and this is probably true for most people doing pain medicine, that spine-related pain is probably 75%, 80% of what I do.
Wow.
And among, in that, low back pain is certainly more common than neck pain. And so, I don't know the split with neck versus back, but it's probably 60-40 for back pain versus neck pain.
Well, wait, let me interrupt you there, because I was just thinking about that this morning. And it would seem that, to me, based on my clinical experience and talking to folks, that low back pain is far outweighs the number of neck pain individual cases, but it seems like the neck pain is more trauma related. They've had a whiplash or there's been some kind of trauma versus a lot of low back pain that just is, I hate to call it an ordinary disease of life, but it seems to be almost in that category.
Yeah, it's an interesting question. So Gordon Waddell is a famous spine surgeon that has written extensively in the space, and he's often credited with the Waddell test that we do sometimes as tests, for malingering. But he has written a fair amount over time in a book. There's a book called The Back Pain Revolution. But one of his criticisms of how we approach back pain, especially, is that we often confuse the symptom of back pain with the disease. That, again, back pain is an issue that we all get backaches. Everybody gets, just part of the human condition. And most of the things that cause back pain are attributable to either genetic predispositions, to mechanical issues that are going to cause pain, or microtrauma, little bits of wear and tear that add up from things that we do. And I think we maybe in our mind think of neck pain as maybe being different and more related to trauma and car accidents, and there certainly are. Those are risk factors for developing neck pain. But again, especially as society changes and we're on phones and computers and we all slouch, we do things posturally that feed into it. That I don't think it's that different.
Okay, all right. It's interesting how we get certain perceptions that may not be reality, but in our own little bubbles, it's like, oh yeah, I was in a car and got rear-ended, and I've had neck pain ever since. And so I guess those stories stick with you a little bit too. So, all right, let's get into low back pain. So tell me kind of your overall philosophy from when the patient enters through diagnosis, and then we can talk about some of the specific treatments that y'all are doing.
Yeah, one of the things that is, I think, true, in whatever, kind of pain issue that you're treating is, listen to people's stories and trying to identify, it's pattern recognition, right? We're trying to identify patterns of either pain or disease that again, we can identify and use to help subgroup, back pain. And so again, when we talk about back pain, we tend to have this kind of very monolithic notion of it, but treating back pain in that way is not super helpful, right? If you have non-specific treatments, you throw that in the mix, some people might get better, but you're certainly going to miss a lot of things. And so, the more specific we can be in diagnosing pain on the front end, and again, subgrouping, people based on, again, either kind of the pathology or source of symptoms, then that allows us to craft more specific solutions. And so that's a big part of what I do is, and some of this is related to working with surgeons and having an eye towards, again, even if somebody needed surgery eventually, I'm always trying to clarify, what the pain generator is.
Right.
And so when I, have people come into the office, they talk to me about it, and, as I listen to their history, there are certain patterns of pain that are consistent with facet kind of joint related pain in the back. And again, a lot of that you can just hear, talking to somebody even without examining or looking at imaging. Other people may have more kind of disc related pain, or there's kind of a newer category of pain that we call vertebrogenic pain. And then some people have primarily neuropathic, kinds of symptoms. And so again, a lot of what we do in approaching that is, again, first listening and then using the exam, and sorting through to try to clarify as much as we can the pain generator.
So what would be some of the common descriptors for somebody that has more of a facet issue versus a discogenic problem?
Yeah, we tend to kind of divide pain in a couple ways. So one, we divide groups into, people that have mostly back pain as opposed to mostly leg pain, because the treatments, again, kind of diverge somewhat.
Right.
So if somebody has mostly leg pain, then again, that's usually related to some nerve impingement and that invites a certain kind of fix. If somebody has mostly back pain, back or butt pain, then we kind of divide them into people that have pain related to the anterior column of the spine, which would be the disc and the vertebrae, or the posterior column. So that division of anterior versus posterior.
Right.
And usually people that have facet-mediated pain or posterior column-related pain, they're going to have pain that's worse with standing for a long time. It's worse if they bend back at the waist. As a contrast with that, people with more kind of disc-related or anterior column pain have pain that's worse with sitting, bending forwards, lifting.
Right.
And those rules don't always hold entirely true, but those patterns I think are pretty common, and again I think go a long ways to help sorting through what's causing the pain.
Yeah, it's amazing what you can accomplish when you actually spend some time and listen to the patient. I had a very famous professor tell me that if you just shut up and listen to them, they'll tell you your diagnosis.
Yeah.
Yeah.
But
again,
that's a hard thing to do, though, right? It's
is
hard when because you want to jump into your thing and do your thing,
right,
and it's hard to listen.
Yeah, and then sometimes you're listening, and you've got your bias. You're thinking they've got something that they may not have, or that may only be a component, and then all of a sudden you're thinking, "Oh, I better start barking up this tree because this is where I need to look." And then all of a sudden they'll throw out a little clue that takes you off of that, and if you hadn't spent a little extra time listening to them, you would have missed that part.
Right.
Yeah. So.
Yeah, there is certainly an art to that. And it's hard, right? Because we have things and we have procedures that we listen to somebody and think, oh, this is the fix. And we get, sometimes tunnel vision with that process.
Right. Well, I'm getting less tunnel vision as I've been humbled over my clinical experience, because humans are complex machines, and we try to identify these pain generators, but then you also have to think about, well, what are the other things biomechanically, metabolically that are going on to exacerbate that pain generator that you appropriately diagnosed? So it's these are complex situations.
Yeah, it is complicated. And then there's always the psychological or emotional component, right? That you have people that come in pain, and that affects people in lots of different ways. And so, as we talk to people, an important part of that interaction is trying to, give people hope again, and, framing expectations. And so all those things are, an important part of that process of treating somebody.
Right. So, all right, let's say you've made the diagnosis of facet pain. That's your go-to now for this particular patient. What are some of the things that you're doing for that particular, I mean, you guys have new innovations all the time. So bring us up to speed.
Yeah. So say somebody has kind of joint-related back pain or facet-mediated back pain. Again, a lot of that we can get from listening to somebody and examining them. MRI and imaging tools are helpful, but again, don't necessarily rule in or rule out whether somebody's pain is coming from the facet joints. And so usually an injection is the first diagnostic tool that we use to really confirm that. So if we suspect somebody has facet-mediated pain, we do often a diagnostic test called a medial branch block, where you put just a little bit of numbing medication or bupivacaine, by that joint, and then you have them go walk around and try it out. And you're just trying to kind of take that off the table and see if, when you take this off the table, how much of your pain is facet-mediated.
Right.
So that's kind of the confirmatory test. And then historically, the fix for that has been a procedure called radiofrequency ablation, where you just cauterize or burn the little branch of the nerve to those joints.
Right.
And that can be a good long-term way to address this kind of facet joint-mediated back pain. We also do some injections in the joint. So we'll do some cortisone or steroid injections. Certainly the thing that I think is kind of most interesting is the regenerative kinds of injections that have more upside potentially, or certainly that's the hope. And so we do a fair amount of PRP, or platelet-rich plasma, in the facet joints. And there's some data published, not a ton of data published, but certainly some smaller studies for the facet joints in the spine. There's more data published for PRP and regenerative injections in knee arthritis, for example, just where there's big numbers. So PRP, we do a fair amount of. I also do some stem cell kinds of procedures. So whether that's typically they're autologous stem cells, so derived from somebody's own bone marrow or fat.
Right.
We do those kinds of injections again in the joint.
So radiofrequency ablation, we started adopting that in the early 2000s and relied on all of the pain management literature because there was virtually nothing published really from a peripheral nerve standpoint back at that time. And so we were able to, kind of get some insights as far as mechanism of action and that type of thing. One of the things that I still remember is that most of the literature said that the RFA in the spine, you might need to come back at 6 months post or 12 months post and, kind of inform the patients that this may need to be repeated in the future. And so we started telling patients when we were doing radiofrequency ablation of very small nerves, like let's say the medial calcaneal nerve, and I'd tell them, well, it's probably going to, at first I would tell them, it's probably going to come back, so we'll have to do this again at 6 or 12 months. And then they were still good at 6 or 12 months, and then they were good at 6 years. And so I think peripherally it was a lot different maybe than what you all experience in the spine.
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen.
Yeah, I don't know. There certainly is. There are different responses to ablation, and again, we use ablation in medicine pretty broadly. People have cardiac ablations and vein ablations, and so in some ways, it's kind of a blunt tool to fix things. Right? Someday, I'm sure we'll have a more elegant tool than just cauterizing or burning nerves.
Right.
But in the spine, the literature is such that on average, people get about 10 months of relief, and then those nerves can grow back together. But that's not true of all nerves. So we have another procedure that we do for more, again, kind of anterior column pain. So again, I'm jumping around a little bit here. But so again, facet-mediated pain is one subgroup of folks for people that have pain from the disc and the vertebrae.
Right.
And there's a procedure where you can cauterize or burn a nerve to the end plates of the vertebrae. And that procedure is kind of a newer procedure, and it's been really helpful for again, that group of people that have pain related to disc vertebrae. And that nerve, when you cauterize or burn it, it doesn't seem to grow back. It's not a myelinated nerve, and so it doesn't seem to grow back. And so when you do that one, it's probably good forever.
And so what are you sticking the needle into the disc itself, or where are you ablating for that?
We're ablating in the vertebrae. So it's the
Oh,
basovertebral nerve
okay.
inside the vertebrae. And so, again, it's not, so some people have, so again, going back to our subgrouping, if somebody has posterior column pain or facet mediated pain, if they have more pain that's worse with sitting, bending forward, it's often the disc or the vertebrae. And one of the things that you'll see in those kinds of people is on their MRI, they'll get, tears in the discs or bulges in the discs.
Right.
Or as that kind of process of degeneration of the disc occurs, they often get end defects in the end plate of the vertebrae. So it's not just the disc bulging out and pushing on the nerves, but you get these defects in the end plate of the vertebrae, and then you get this inflammatory process that starts inside the vertebrae. And on an MRI, you'll see these inflammatory changes in the end plate of the vertebrae called modic changes.
Okay.
And that's kind of, it's a biomarker in a sense, kind of as close as we get to a lab test for back pain, in the sense that once people get modic changes, it's a pretty strong predictor of the presence of back pain. And so you have these changes in the end plate of the vertebrae, and there's a nerve inside the vertebrae called the basovertebral nerve that is the communicator of that pain. And so with this procedure, you take a trocar and an instrument,
Okay.
you go travel down the pedicle inside the vertebrae, and then you're cauterizing that nerve.
Okay. So it's more of a cauterization strictly inside the vertebrae versus the facet is outside of the articulation.
That is right. Yeah.
Okay.
So for the facet, you're ablating the medial branch nerve that, again, is kind of communicating the pain from the joint to the nervous system. And
you mentioned a couple of things that I would like you to expand for our audience, for their understanding and mine as well. And that is the term modic changes, and then also what exactly is the vertebral end plate. Can you give that in layman's terms so they can understand what that is?
Yeah. So the spine is, in the body, we have all kinds of different joints, right? You have joints that some move in just one plane of motion. Some, like the shoulder, have very kind of broad kind of planes of motion and are more complicated joints. In the spine, again, I was talking about this anterior and posterior part. And so in some ways that division is artificial because they kind of, they're very interconnected. But you have the vertebrae, the bony elements in the spine, and then you have the disc is the shock absorber that sits between it.
Right.
And so that joint, that intervertebral, disc kind of joint segment is, it has motion. It bears a lot of stress, load stress, kind of axially, up and down the spine. And so the disc has two parts. It's got a fibrous outer part, and the inner part's kind of more jelly-like. And sometimes you'll get tears in the fibers of the disc. So you get, sometimes you'll see it on an MRI. It's an annular tear, like a fissure in the fibers in the back of the disc.
Right.
And that creates, again, kind of a weak spot in the disc. And sometimes that allows the disc to bulge out. And that's what may create sciatica and leg pain.
Right.
But also as the disc gets wear and tear, it's not just, it's not just about bulging back into the space, but as you get wear and tear, you lose some of the cushion in that. And it's a lot like when somebody has knee arthritis and you lose cushion in the, the knee joint, you tend to get inflammation in the bone and you get changes in the bone framing that joint. So the same thing happens in the spine. You get these changes in the end, the vertebrae framing that disc because they bear more stress because the shock absorber is not doing its job as well. And that change then creates kind of inflammation and actually an increase, the body gets inflammation and it increases the density of nerve fibers in that area. So you actually become kind of hypersensitized, when there's wear and tear in the disc. And then that's what we'll see. An MRI, modic change is just the change on the MRI that you see that is reflective of that and that process going on at the end of the vertebrae.
So there was a push away, a while back where they were doing a lot of intra-disc type procedures where they were trying to get the nucleus pulposus sucked back in or, all these different things. Has that kind of shifted now? Is that still the focus of how you all are attacking this, or is that
Yeah, I mean, it's been a problem for a long time, right? And so there's always been this group of people that didn't get better with facet ablations, or they don't have, sciatica and leg pain. And, surgically, there wasn't necessarily something to go in and cut out.
Right.
And so years ago, they did chemopapain injections in the disc, where they would inject chemopapain, and it would have this kind of, trying to, block the nerves. It had this kind of effect that was kind of dehydrated or really kind of dried up the disc. And
Almost like a prolotherapy.
a little bit, but it was a little bit more injurious to the disc
Okay.
in the sense
All
that
right.
it really kind of, and the data was not compelling over time, right? It just didn't
Right.
hold up. It was not a great tool. And
Right.
so that was kind of one option for that for a long time. IDET was a procedure where they would take a tool and they would go into the fibrous part of the disc and try to cauterize the, not necessarily the nerve, but the fibrous kind of outer part of the disc, kind of shrink wrap in a sense, the disc.
Right. All right.
And the data was okay, but again, not great for that. Some people would do, if people had back pain on an MRI and they had a disc that looked like it had wear and tear, they would do a discogram, a study where you would inject into the disc and create
Right.
pressure and see if that reproduced pain. And then they would surgically go in. The only fix surgically was to fuse those folks. And so, again, it's been this subgroup of people that have been undertreated by the options that we have, just to have great tools for those people that had kind of this disc or vertebrae related pain. And so, this basovertebral nerve ablation became available in the last 5 to 8 years or so. And so again, it's not relevant for everybody, but for that subgroup of people that have modic change, pain's worse with sitting, bending forward, they tend to have this, what we classify now as vertebrogenic pain. And so this procedure is a nice tool to cauterize or burn that nerve. To, again, the end plates of the vertebrae. There are other things that are out there, and the space is always evolving. So there also are people do intradiscal injections of stem cells or PRP.
Mm-hmm.
And there are some studies that are right now in the phase 3 trials with the FDA for intradiscal injections of like culture expanded disc cells. And so it's a space that's evolving. There's always new things.
Right. So the percentage of folks that come in with, and I hate to say this because there is no such thing as anything common, because every condition has its nuances based on the individuality of that particular patient. But a patient comes in with, let's call it common low back pain for anything better right now at the top of my mind. But what percentage of them are you guys able to keep from going into a surgery? And I'm not including these, like the ablations are not what people, I mean, sadly, there's this perception that all back surgery is the same, and clearly it's not. So, I think when people talk about the horrors of back surgery and everything, they're more in the fusion category rather than some of these other techniques that you guys are implementing. But I guess my question is, how many people end up having to have laminectomies or fusions versus those that have, lifestyle modifications and no intervention, versus the mid group that would be what I would call the lesser invasive interventions? And that's the way I ask that question is really horrible because I'm all over the map, but I think you understand what I'm talking about, right? Or asking. Yeah.
I mean, most folks, don't need surgery for back pain, right? It's really for a small subset of all those folks. And, again, I kind of alluded to this, framing expectations is important in that back pain's complicated. It often takes a lot of years to create the issues that are the source of pain, right? I mean, it's either, too much sitting as a society, or all these things, that micro trauma that build up, that, talking to people in a way that's realistic helps to frame expectations. And often we can make things better, and we can take, part of their pain off the table. But there's generally not a miracle cure that's going to make everything go away overnight.
Right.
And so, again, kind of having that discussion, framing expectations is helpful. But, most things we can fix non-surgically. Again, that's probably on the order of 95% of, folks with back pain, don't need, really invasive things. And then, just as I approach, kind of treating people, the injections I think are great tools, and ablations and these other tools are great. But, as part of what we're doing, I'm always talking to people about exercise things and, think tools that can empower people so that they can manage it and have some things to do that's not,
Right.
Relying just on seeing me. And so as we talk about that, again, I think that's kind of getting at your question, but most everybody, I'm talking to, I'm sending them home with exercises they can do, and then we might do procedures to try to kind of facilitate progress. But really, exercise, kind of all the things that we can recommend, is kind of the best medicine for things. And then, again, in a small subset of folks, surgery can make sense. Infusion, it's a great surgery. People can have good outcomes in the right person, right? I mean, it's
Right.
just, it's the right fix at the right time. And so it, can be a good tool, but when misapplied, it creates all kinds of other issues.
Right. Well, it's very interesting that if you can give the human being a little bit of a chance of getting over their pain, and then they do all of the other things that, like core, stretching, exercises that I'm sure, you've already referred to, it's amazing what the human body can do to recover if you just give it a little bit of a chance to get ahead of that pain curve.
Right. And it's hard, right? I mean, again, and that's true of lots of things that we're treating, and that, pain really wears on folks. And there's this emotional
Right.
toll. People may not be sleeping well, and, all those
Mhm.
things really can snowball. And so if we can, again, often kind of interrupt that pattern of pain for folks and do something to buy relief, then, then it makes it easier to, if we can take some of that off the table, then they can work on exercise or lifestyle changes or, diet. I have some people that come in and, get motivated, and they go to a really low anti-inflammatory diet and
Mhm.
feel great all over. And that makes a big difference. But,
Right.
or exercise, I get lots of people that come in and, they feel guilty because they can't exercise. And so maybe they can't lose weight as much as they would like, but pain gets in the way of that, right? And it makes it
Right.
hard to exercise and do those things.
Right. Well, and the thing is too is that it's a catch-22. So if you're in pain and you can't sleep, well, now you're not manufacturing the neurotransmitters you need to downregulate the pain. And there's a lot of compelling data now on what pain does to the immune system. So a lot of these folks, especially when they have peripheral neuropathy, they're inflamed. They're like literally people on fire. So it's not just a one condition, one treatment, or one disease, one pill situation. In my opinion, I think you have to kind of look at it from a global perspective, and then integrate everything. Not just, this is my procedure and that's all I'm going to do. Go home and continue doing all the bad things you've been doing.
Right.
Yeah.
Yeah. I mean, I'm sure with peripheral neuropathy, right, you see the same kinds of things that,
Right.
but, in your case, if you can help, right, if you can take part of that pain off the table, then it
Right.
makes it so much easier for people to make lifestyle changes and the other things that then,
Right.
again, snowball, but in a more positive direction.
Yeah. It's amazing. If you can take a patient that is like they say 12 out of 10 on the pain scale, which I don't think that's possible, but let's say it is, but you bring them down to like a 5 or a 6, it's life-changing for them, because now they can sleep a little bit better. They are more motivated because they have a decreased pain. They're almost to a functional capacity of being normal. Even though they have pain, they can deal with that 5 or 6 pain where they couldn't deal with that 10 out of 10 or 12 out of 10 pain. So there's a lot of things that go into it. And I think if patients realize that this is a course of small integrals. You have to do these things, and it's not like this is the one pill I'm going to prescribe and you'll be better in 48 hours and get out of here. I never want to see you again. That just isn't going to work. It's not realistic. So I think you're saying a lot. And then the other thing that I've yet to see a pain patient that's been in pain for more than 3 months that doesn't have some component of either depression or anxiety, but usually both.
Yeah. Yeah, and there's a fair amount of evidence that the presence of depression and anxiety tends to negatively affect a lot of the treatments that we do. So there's a lot of literature in the spine space that if people have undertreated depression, that that dramatically decrease the likelihood of having a response to a cervical epidural injection or even a spine surgery. And so, again, I think it's crazy to, just to ignore that part of it and to be just a technician and think I'm going to put in screws here or inject this and that's going to fix everything. That we've all experienced it, right? If we
Right.
have, a pain issue, we have something going on that, we don't sleep well, we're more irritable or, those things.
Right.
And so I think, that's part of the art of, medicine, right? Is kind of listening to people and helping to address that part of it while we can't have these technical tools to address other parts.
Right. No, there's a lot to be said about that. Any advice for people that, before we wrap up, any advice you have for somebody that says, okay, I'm starting to get some low back pain, but it's not that bad. If they get in to see you, you can maybe give them some things that would prevent it from getting worse. I know some of the most dangerous words in medicine is maybe it'll go away.
Yes and no, right? I mean, certainly with back pain, people have episodes and it does go away.
Right. Right.
In most cases. Yeah, I mean, I think, again, there's a lot to be said for preventative, medicine, and that's true, in lots of senses. The more we can stay ahead of that. There was, a few years ago, there was all this, angst about, sitting too much, that sitting was the new smoking.
Right.
And again, some of the literature maybe hasn't panned out in that way, but there are certainly these patterns that we have as a society. We sit too much. We're not walking as much as we should, and some of those patterns create imbalances that then set somebody up to have back pain. And so just being aware of that and you thinking of exercise as medicine, can be really helpful for back pain.
It's also helpful for depression.
It is also helpful for depression. And again, there's protective effects, just from, exercise, kind of more generally. I'm trying to think of tools that I like. I often will, again, exercise.
What about inversion tables?
Yeah, the data is kind of mixed. Some people love them. Yeah, I mean, the data is not super compelling. There is some evidence for, again, it's slightly different than inversion tables, but traction, cervical traction is a little bit more, because it's a little bit easier to create, effective distraction. And so cervical traction, the data is a little bit better than inversion tables and traction for the lumbar spine, but some of the things can help.
I actually had a very bad episode of back pain, probably around 2004, 2005, when I was out in Arizona. And I came across this pain management group that had this machine called the VaxD. And they strapped me on that thing, and it was crazy. Within about 15, 20 seconds, the pain just went away. So obviously I had an impingement on a nerve root. But I ended up doing about 20 of those and found it very, very beneficial. And I have a inversion table. I don't know that, like you say, it's mixed, but that traction thing, man, that was pretty powerful for me.
Yeah, the VaxD is still around, and people still do, that, again, it just is a way to create, kind of more impactful kind of distraction and unloading. And so certainly that, is an option. I recommend a lot of, for exercise things, a lot of exercises that are what we call posterior chain, where we're trying to work on, strengthening the muscles that pull us up and back, because we're so much time on computers and forward.
Right.
So there's a guy that I like named Eric Goodman in LA that talks about foundation training and a lot of posterior chain strengthening that I recommend for a lot of folks. That's a great resource. Just, again, there's not one fix that's perfect for everybody, but for most folks, those kinds of exercises are relevant because they, again, counteract the imbalances that we create with other patterns in our life.
Right. Shane, thanks so much. I really, I always enjoy talking to you. We got to get together more often because I always learn so much from you. But can you tell people how to find you guys and your group if they want to get in contact with you?
Yeah, I would give social media or give some reference, but I don't really have social media. I'm not really out there on social media. I practice Axion Spine and Neurosurgery again in the North Atlanta area. You can find us at axionspine.com.
Okay.
And I appreciate you having me on here. I always learn lots from you, and you're always on the leading edge of things.
Well, Unfortunately, I just am very curious, and I love to hang around with smart people like you. So thanks for coming on. Really appreciate it.
You're very kind. Thank you for having me.
And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.